But no chemo, no chemo, okay.
And then say,
It doesn't have any side effects.
it's recording now.
Oh, she got the pop-up here.
Yeah.
Oh, you did? Okay. Hi, everyone. Thank you so much for coming. We're going to get started. If you need the restrooms, just learn to go out this door to the back and then to the right next to all the brochures on the wall. Let me introduce today who we have going on. So we have Danielle Dondeville, earned a master's degree in human genetics and genetic counseling from Stanford University School of Medicine. As a genetic counselor at the Cedars-Sinai Samuel Ocean Comprehensive Cancer Institute, that was long, for my bilingual tongue, she provides invaluable hereditary cancer risk assessment, counseling, and support to individuals and families navigating the complexities of cancer diagnosis. And joining her is John Lee, who is the Associate Director of Clinical Operations at Samuel Ocean Comprehensive Cancer Institute. John's expertise lies in genetic counseling, risk assessment, and research on hereditary cancer syndromes. Wow, my Spanish is coming up. Together, both of them will bring a wealth of knowledge, experience, and dedication to empower us with insights into the hereditary aspects of cancer. So please join me in welcoming them. And this is a heads up. The meeting is being recorded, so we'll save the questions to the end, and that way we can edit out any personal information. We'll also stop it before the questions start.
Thank you.
And a round of applause. Thank you.
Thank you. Yeah, so if you have non-personal questions that you want to stop and ask during, feel free to. But any personal questions that you don't want recorded, yeah, just keep to the end. But thank you for the introduction. I'm Danielle, and what she didn't say is I'm born and raised in Pasadena, just about 5 minutes up the road here, so it's really special to be back here, so thank you. And John as well, not born and raised here, but lives about 3 minutes away from this center, so we're really happy to be here. Thank you. Some people have already said, you know, what their interest is in being here, but have most people heard about genetic counselors previously? A little bit, okay. So our talk today is really focused not specifically on specific hereditary cancer syndromes, but really just helping bring up the topic and conversation of, you know, who should get genetic counseling, who should consider testing, and just some of the things to consider before undergoing genetic testing. So essentially the overview of what we'll talk about today: what is genetic counseling and testing, how is it actually performed, who should consider undergoing testing, and why and maybe why not to consider doing testing. So very basically, what we do as genetic counselors is essentially just help people understand and adapt to sometimes really complex medical test results, essentially, and help to understand the implications of genetic test results. So we are master's trained, as she said in the introduction. We both went to master's programs to do genetic counseling, and we are licensed and certified in the state of California. So each state does have different certifications. So just a little bit more, we provide information about genetics, inheritance, specific genetic conditions. We discuss the risks and benefits and limitations of genetic testing. We interpret results and help patients really make informed decisions about their medical care. And we provide support to patients, their families, their healthcare providers, and their community as well. And this is just a schematic. John and I both practice in the cancer realm, obviously, but there are genetic counselors in a variety of specialties, and maybe some of you have seen them in other specialties. So, for example, we have colleagues at Cedars, at least, in neurogenetics. So they see patients with family history of Alzheimer's, ALS, just to name a few, Huntington's disease. We also have a genetic counselor colleague in the cardiology department. And where genetic counseling really started was in the prenatal realm many, many years ago. So genetic counselors helping couples with family history of conditions to conceive and test, you know, before and during pregnancy. What we don't do is we don't clone people. So sometimes people come and say, can you keep my DNA and do something with it in the future in case my kid, you know, want another version of me. We can't do that yet. And we don't help parents make designer babies, even though some people will ask, you know, what can you do with this information? Can you help us do that? So for those of you who have not been through a genetic counseling visit previously, it's generally a two-part visit process. So in the initial visit, we will sit with you, elicit personal and family history. We do what's called a risk assessment and discuss generally hereditary cancer syndromes. We will coordinate testing and sample submission if you're wanting to go through a testing, and then also in some instances, coordinate insurance authorization, or at least help you with that process. I really like to stress that just because you meet with a genetic counselor does not mean you have to go through a testing. We both feel strongly about it being an option. So even though it may be strongly suggested to you by your medical doctor, at the end of the day, it's your decision on whether or not you want to go through with testing. In the follow-up consultation part, we disclose the results, we interpret them and help you basically figure out, what do I do with this? Who do I inform? Can I do anything about it, really? We provide medical management recommendations, obviously offer emotional support where we can, and identify people in the family who could benefit from testing. We are not medical doctors, so we don't order any testing. We refer back to primary care doctors or other specialists to manage your care. So the first thing we do when you come see a genetic counselor is we take a large family history such as this. So this is the technical term of this is a pedigree. It's essentially just your family tree. So when we sit down with you and we talk about your personal history, the things that we will be asking are reviewing major illnesses, hospitalizations, surgeries, and obviously if someone has a cancer history, we'll review that as well. I can't stress enough, this is just my personal service announcement, keep records. It's really important for us to have exact diagnoses, places where the cancer started, ages at diagnoses, and when you're going through a cancer diagnosis, a lot of that goes, in one ear and out the other, and maybe in 5 to 10 years from now, that could be something you don't recall. So it's really, really important to keep records when you can, so that when we ask these questions, you have that information. We'll shift to talking about a family history. So again, this is the pedigree that we'll draw. Just to orient you, circles are females. Generally, the arrow will point to the person that we're talking to. Squares are males. So in this case, we're talking to a 31-year-old female. And this essentially is both sides of the family. So the maternal side of the family and the paternal side of the family. We ask about aunts, uncles, nieces, nephews, grandparents, obviously. So that's kind of part of what we do during our genetic counseling visit. So just a few more things about taking a family history. We ask generally about 3 generations. It's okay if you don't have all of that information. Not everyone knows everything about their family. You could be adopted. You could have not have any contact with family members, and that's okay. What you can give us can be helpful. We ask about both sides of the family. I can't tell you how many times patients will come and say, oh, well, all of the cancer is on my dad's side of the family. It's paternal, so it doesn't matter. I can't inherit breast cancer from my dad. And the fact of the matter is you can inherit these genes from maternal or paternal sides. It does not matter. So we really ask about both sides of the family tree. And when it comes specifically to cancer history, the things that are super helpful for us and that we'll ask you about are, where did the cancer start? So where did the primary cancer start? Are there any second primary cancers? So what does that mean? Is there a cancer that originated completely separately in a different part of the body? What was the age of onset? Super helpful. And if anyone in the family has had genetic testing. And again, keep records. And if people in the family have had genetic testing, we will ask for a copy of results to review those. And we do ask about ancestry or country of origin. Some people ask, well, why does that matter? There are certain populations, such as the Ashkenazi Jewish population, where there are certain genetic mutations that are more frequent than in the general population. So we ask about that for that reason. So what is genetic testing? We're not going to get into the super nitty gritty, but essentially every cell of our body, we have DNA. This DNA is our code that tells our body how to grow and function and do all the things that we need it to do on a day-to-day basis. So with genetic testing, we're actually getting down to the very granular genetic or gene level. And it's like a fancy spell check is how I describe it to patients. We're reading through your genes looking for any spelling errors. And if we find a spelling error, we then look into how does that really mess up the gene? How does it keep the gene from doing its job, which in most of these cases is to prevent cancer. So with genetic testing, we are essentially getting a sample, which I'll go over in a second, in terms of how we do it, and basically reading through a certain subset of your genes. We have over 20,000 genes in our bodies. We're not looking at every single gene in this setting. We're looking at anywhere from, I would say, 2 to about 90, 100 genes related to cancer specifically. So just to reiterate what I just said, when we have a normal gene, it reads perfectly well, like a normal sentence, no spelling errors or typos. We essentially get a healthy protein which can do its job in our body. When we find a mutated gene, what essentially that means is a spelling error. The protein becomes damaged and it can't do what we need it to do in our body. So we're essentially looking for whether someone has a mutated gene that is increasing risk to develop cancer. So there's been a huge shift in testing, I would say in the past 10 to 15 years. It used to be that we'd have to do what's called a single gene test. We'd have to order one test or one gene at a time, look at that gene. If we didn't find anything, shoot, or we'd have to pay and do another test. So that was really traditionally used when a person had a specific syndrome or family history that was really suspicious to us for a specific gene. Obviously, the disadvantage is that we could miss something. So over time, we've been able to do what are called multi-gene panels, which essentially looks at a bunch of different DNA, different genes at one time with one sample. That allows us to cast a wider net per se. It allows us to test people who don't necessarily need one specific genetic syndrome or one gene of interest. There is disadvantages to this as well, in that we can find things that are completely incidental or surprising, but also find a lot of things that maybe we just don't quite understand yet. So several factors go into this decision. Obviously, the patient's personal and family history, patient preference. We'll talk to you about what your level of comfort is and how a broader test feels to you as compared to a more targeted test. Some patients have a lot of tolerance towards uncertain findings. Some have zero tolerance for uncertain findings. So that's part of our genetic counseling visit, is getting to know you and to understand what is your comfort level with this type of testing. And we'll also, again, review insurance coverage and cost, which unfortunately a lot of times can dictate what patients are able to get covered. So super busy slide, not meant to be read. This is an example of a multi-gene test. You'll see this is on this side, all of these little 3- and 4-letter words or different genes associated with risk for cancer. Across the top, you'll see, for example, the purple line is breast and gynecologic genes. So when we decide on a test, we can do all of these at one time. You'll see that these genes span from being associated with breast and gyne cancers to prostate cancer to sarcoma. And some patients will be just more comfortable with maybe just doing the genes in the purple line, just testing for genes related to breast and gynecologic cancers, given that that's what we see in their family. So the options are there. We discuss it and you can decide what you feel comfortable doing. And so lastly, before I hand it over to John, how do we do this testing? We can get DNA, genetic code, a number of different ways. In some instances, some samples types are better than others. Most of the time we are doing blood or saliva. A blood sample is collected just like in a normal purple top tube, like you go when you get your just normal routine blood drawn. Generally we draw about 2 tubes of blood for this testing. We can do saliva, which essentially you spit into a tube, that looks like a lot like this. It takes usually about 1 to 2 minutes to get enough saliva to produce a good enough DNA sample. Of course, your DNA is existent in your hair and skin cells, but we're not plucking you when you come to see us, or we're not shaving off your skin, but there are times where we need a different type of sample. And once we collect the sample, it takes about 2 to 3 weeks for us to get the genetic testing results back. Okay. That's our review.
Thank you, Danielle. So what I wanted to talk about a little bit is really who's a good candidate for genetic testing and kind of why should you consider testing and potentially why not as well, because it's not always specifically a straightforward situation for everyone. So in terms of the who should consider testing, I will say this has changed really rapidly and continues to change. Essentially, almost every year there's a new paper that's published by various academic institutions or other research organizations where they do testing at kind of a larger scale and find that essentially our current criteria is missing a lot of patients that actually have genetic mutations. So what I tell you today is kind of very loosely current criteria, but a lot of this is expanding to more kind of a universal-based testing in the future. So currently, some of the main things that we look at are really the age of diagnosis. So as Danielle was mentioning earlier, the age that someone is diagnosed is really key to us. And the reason for that really is when you think about a cancer like breast cancer in particular, first off, breast cancer is very common for women to develop. It's about a 1 in 8 chance in the general population, and this is with no genetic mutation at all. Average age of diagnosis of breast cancer in the United States is about the age of 63 approximately. We do find that more or earlier ages of onset, specifically breast cancer diagnosed before the age of 50, is a higher indicator or red flag, so to speak, in terms of finding a genetic mutation. So meaning that the earlier the onset of the breast cancer, the likelier or higher chance that it could be hereditary. But of course, that we still see some patients with breast cancer at 30 or 40 or 50 that do genetic testing and still come back negative, but it is, again, a higher predictor that they would have a genetic mutation. Also, the type of cancer really matters to us as well. The rarer, in very loose terms, the rarer the cancer is, the more likely it is to be hereditary. So as an example, male breast cancer, it's not something you hear about every day. That is certainly something that is much more likely to be hereditary than a more common type of cancer. And then certain types of sarcomas, especially childhood onset, things like that, similarly can be more correlated with certain genetic predispositions. And then multiple cancers. So if someone presents and they say, okay, I had breast cancer at 35, I then had ovarian cancer at 45, and then maybe a colon cancer at 50. Anytime someone starts to have multiple types of cancers, that is more concerning to us as well. And then also, typically when we think about genetic testing, the person in the family who has a cancer is much more useful and informative for genetic testing than someone who has not had cancer. So oftentimes we'll have women come in saying, okay, I'm 30, my mom had breast cancer at 50, my maternal aunt had breast cancer at 55, and my maternal grandmother had breast cancer at 45. And I've kind of always known about this family history. I'm really concerned about this. I want to do testing. One of our first questions usually will be, have any of your family members done genetic testing, specifically the people with the cancers, or are they available and willing to do genetic testing? The reason that testing the family member with the cancer is more informative is really that gives us a more direct answer. Is the cancer in the family hereditary or not? So an analogy I like to use is think about an apple tree. So say you have an apple tree that for 20 years in a row gives you only red apples, and then in the 21st year it gives you 99 red apples and 1 yellow apple. If you really wanted to kind of dig deeper and find out why did I get a yellow apple this year, you'd probably do a lot of testing on that yellow apple, probably some cross comparison with some of the red apples, but you'd really focus a lot of the testing on the yellow apple. So it's kind of a similar situation here. If we test the person with the cancer in the family, if they are found to be positive, then we know exactly what we need to be looking for the other family members. And if conversely, if they test negative, most oftentimes genetic testing is not really that necessary for the family members that haven't had a cancer. And then there are certainly situations where family members will come in and say, everyone with the cancer, unfortunately, is much older and has passed away, or they're not willing to test. We can test what we call unaffected patients in those scenarios. It's, again, not as great, but it is still certainly doable. The biggest limitation there is that if that person that has not had cancer tests negative, we're still left wondering, are you negative because there's no actual genetic mutation in the family? Or was there a genetic mutation in the family that you did not inherit? When we think about these genetic mutations, the rate of passing them on from a parent to a child is technically usually a 50-50 chance. It's not nowhere close to 100% chance that it would be passed on. So there are possibilities where family members, like a parent, could have a genetic mutation and have a cancer related to that genetic mutation, but their child kind of got lucky, so to speak, and that mutation wasn't passed on to them. So that's when possible, testing the person in the family with the cancer helps us the most and gives us the best and most direct answers. And then when we think about cancer in general, a lot of patients will wonder, why does cancer happen? And when we really think about it, the fact of the matter is genetics is really one small part of the chart here. A lot of it is not truly hereditary. A lot of it is either based on environmental factors, lifestyle, random chance. As we get older as well, basically over our lifetime, our DNA replicates itself, and the more times we replicate the DNA, the higher the chance there is an error. And then family history can play a role as well, and then of course genetics. So here's another way to visualize it. When we think about cancer, we think about three large groups. They're called hereditary, familial, and sporadic. And as you can see, sporadic is kind of the pinkish color. That's actually the largest amount of cancers that we see. These are the ones. Sporadic to us means this is not hereditary at all. It's either due to, again, environmental, lifestyle, aging, random chance, etc. There is no true hereditary predisposition here. The smallest part of the pie, the dark blue, is the hereditary portion. That's what we focus on. This is only actually about 5 to 10% of cancers, and this number oftentimes surprises patients. They usually think it's flipped. For these individuals, these are the ones that when they do genetic testing, we find an actual genetic mutation. Those are the cases that, again, we can do the most for in terms of education, in terms of what the cancer risks are and what the chances of passing this on are. And then the other grouping in the light blue is what we call familial. And we think this is essentially a mix of both genetics and environment. So it's what we call multifactorial. It's not a specific genetic mutation like in BRCA or a different gene, but we think it's potentially a gene that we haven't identified yet, combined with what else is going on. And these are oftentimes when we see clusters of cancer within a family that test negative with genetic testing. So like 3 or 4 family members with breast cancer, but all of their genetic testing is negative. Usually we chalk it up to something familial in these particular situations. And then how do we actually, when we meet with patients, how do we really determine who is a good candidate for genetic testing and who is likely to potentially have a genetic mutation? So going back to the pedigree or family history example, this is again starting with the base here, as Danielle was showing, the unaffected 31-year-old. In this particular case, again, this person has no family history of cancer. This person is very unlikely to have a genetic predisposition. Oftentimes, when someone has a genetic mutation, it doesn't translate to 100% risk of developing cancer. Oftentimes, the risks are significantly higher than the general population. Usually, you would expect to see some sort of related family history. So if someone comes in with no family history, really, most of the time, we're not really going to find anything concerning for them. So here's another example. This is what we would categorize as a sporadic cancer. So we have that same 31-year-old female comes in and says, my mom had breast cancer at 75. My mom, as you can see, has 2 sisters, which are maternal aunts to the patient. The shading on our family trees means the person has had a cancer. Any icon that is not shaded means they have not had a cancer. So in this case, the patient has a sister that's unaffected, as well as 2 maternal aunts, 3 female cousins, as well as grandmother on mom's side, all without cancer. So in this particular situation, some of the things we're looking for, like I mentioned earlier, was the breast cancer at a young age of diagnosis, in this case at 75. In the genetics world, that is not considered to be early onset, so it's not particularly concerning to us. Is the cancer type rare? A female breast cancer, as I mentioned earlier, happens in 12% of the general population. It's really one of the most common cancers that we see, so it's not a particularly rare cancer. Are there multiple types of cancer within the individual? No. And then is there additional family history? No. So in this particular case, it's very likely to be a sporadic cancer, very unlikely for us to find a genetic mutation. There are certain risk models that we can run for patients like this 31-year-old that would take into account family history and gynecological factors to give them a personalized risk of breast cancer. But in all reality, it's very likely that this patient would come back with very close to the general population risk. So it's also important to note there, even though that we don't think there's a genetic predisposition, there still is very clearly a risk of breast cancer, at least 12%. This 31-year-old will still need to do breast screening in the future, typically starting at 40. So that's, something very important to still recognize. It doesn't mean there's a 0% chance. Next example is kind of a familial case. So in this same exact setting, say the patient tells us, okay, I have a father with prostate cancer at 75, a paternal aunt with skin cancer at 69, and then paternal grandmother with breast cancer at 75. As Danielle mentioned earlier, we really can't stress it enough. Both sides of the family are important to us. And honestly, we even have physicians that we work with that still incorrectly think that dad's side doesn't matter in terms of especially breast cancer and things like that. So there's one thing you take home from today, it's really that both sides of the family are equally important. So when we look at this one, when you look at the amount of cancer in the family, that is concerning. A lot of patients will say, I have a really strong family history of cancer. Out of my dad's generation, 2 out of the 3 siblings there had cancer. And then when I look at my dad's side in totality, 3 people have had cancer. And I certainly understand that perspective. When that person looks at that side of the family, there are a lot of cancers. That said, from our perspective, we still kind of break it down into those different categories. Are any of these cancers particularly early onset? No. Are any of these cancers particularly rare? know as well, prostate cancer is probably the #1 cancer for males to develop, and skin cancer, assuming it's not multiple types of skin cancer, oftentimes are, sun exposure related, and it's very common for people to have skin cancers, especially living in Southern California. And then, has anyone had multiple types of cancers? No. Is there a family history? Yes. But then we also look at the types of cancers and really kind of see, do they go together within specific syndromes that we know of? So when people hear of certain genes like BRCA1 and 2, or some people call them the BRCA genes, most of you, I'm guessing, have maybe heard of those. But those are very tightly linking breast and ovarian cancer. So when we see family history, so like say this was grandmother with breast and aunt with ovarian, I would take that as a more concerning family history than this particular example. Or other groupings can be colon and uterine cancer. There's certain kind of patterns that we're looking out for that can help us determine whether it's more or less likely to be hereditary. In this particular case, because these cancers don't specifically go together as neatly in a specific syndrome and the ages of onset are not particularly early onset, we would also likely similarly think that this patient likely has very close to general population risks of cancer. And then the third example, this is kind of one of our classic hereditary family trees. Again, they won't all look as obvious as this. This is certainly, again, kind of just for illustrative purposes. But in this same example, this 31-year-old has a sister that has had breast cancer at 30, father with pancreatic cancer at 50, paternal grandmother with breast cancer at 40, paternal aunt with ovarian cancer at 55, and then a paternal first cousin with breast cancer at 37. Again, very, this one really jumps off the page to us saying, gosh, there's probably something hereditary going on here. Again, it would still be best for someone, if they're available, the people in the family with cancer to do testing first, but certainly this is a case where we can test an unaffected individual as well. This one meets most of the kind of check boxes that we're looking at. So are any of these cancers young? The breast cancers, all 3 of them in particular, are really early onset in this particular case. Are some of the cancers rare? Ovarian and pancreatic are much rarer than breast. That would qualify in our particular situation here. Has anyone had multiple cancers? No, but there's still enough going on in the family here for us to be concerned. And then, is the family history overall concerning? Certainly. Again, these cancers, there's certainly a lot of them, and they link together within certain syndromes as well. So this would be a very classic family history that we would want to test, and I would not be surprised to find a genetic mutation in this type of family. And then, what are the types of results that you can get? So, you're at the point where you've met with a genetic counselor, you've decided to do genetic testing, and it's now time to talk about your results. So there are really largely 3 different types of results that any patient that can have. And honestly, a lot of patients will actually have all 3 of these results. So it's not even a situation where you have only a positive result or only a negative or only uncertain. Starting with a positive result, what this one means is that we've read through someone's genes and we have found a change, specifically a harmful change, which we call a mutation. This is something that is typically inherited, so it's not really the patient's fault that they have this. It's not anything that the person has done or not done throughout their lifetime to cause this. They simply inherited it from one of their parents, either their mother or father, and frankly, their parent as well probably passed it on to them, and so on and so forth. In this particular case, this could help us kind of figure out what's going on within the family overall. It can help us determine maybe not the sole reason that person has developed cancer, but maybe one of the larger reasons. One of the big changes recently as well is that within therapeutics, so we work very closely typically with medical oncologists as well as surgical oncologists. This really helps them a lot in terms of figuring out very personalized care for the patient to say, okay, you have an ovarian cancer that's BRCA positive. Maybe the new standard of care for this patient is something that we call a PARP inhibitor rather than standard chemotherapy, or they try chemotherapy first, and then after that, they go to a PARP inhibitor, something like that. And we found really promising results through various clinical trials that this more targeted treatment when patients have certain genetic mutations is really better than what we were used to be doing in terms of the actual treatment. And then certainly beyond that, in terms of prevention, in terms of figuring out, do these patients have elevated risks of other cancers? Even if someone's had one cancer, do they have a risk of another? Or if the patient's never had cancer, what are their risks of developing cancer? So this really helps us work with your other treating physicians to really sketch out a plan to say, okay, we think this patient has increased risks of X, Y, and Z cancers, and these are the things that we think they should be doing, whether it's extra breast imaging or, in certain situations, preventative surgery. And really, the main one that we recommend that for is ovarian cancer, because as some of you may know, unfortunately, the screening for that right now is still very ineffective. But for most things, we recommend some sort of screening, either more frequently than the general population does it, or maybe if it's for a rare cancer, say it's for thyroid cancer or something like that. Most people in the general population aren't undergoing thyroid screening. but maybe we'll recommend an ultrasound or something like that if we truly think there's an elevated risk. So most of what we would recommend, again, is increased screening. We're not going to be telling patients they need to have 5 different preventative surgeries, but again, there are rare situations where we may recommend a preventative surgery. And then second result is a negative result. This is frankly the most common results patients will get. Positive is probably in our patients 5 to 10% of the time. Negative is closer to 60 to 70% of the time. Negative basically means that we've read through these individuals' genes and they look normal. They look like the regular versions that we expect to see within the general population. In a case where someone's had a cancer, this can be a little bit of a frustrating result because we don't have an answer for them as to why did this happen. I find that it really certainly varies patient by patient how important that is to them. Some patients will say, I've kind of put that in the past and I'm focusing on moving forward, versus other patients will say, I really want to know why this happened so I can either adjust my lifestyle or diet, etc., to mitigate my risk moving forward. But I think one of the frustrating parts about the negative result is, frankly, we don't really know why that cancer developed for that individual. It could be environmental, it could be lifestyle, it could be age-related, but it's hard to really pinpoint further than that. The good news from a negative result generally is that we don't think that that individual specifically has an elevated risk of developing another type of cancer, and then we don't think that they can pass on a specific genetic mutation or predisposition to their children or grandchildren, so on and so forth. And then the last result. This one's called uncertain because unfortunately it's never fully, clear in all these tests. Uncertain does happen about 30% of the time. So if you do genetic testing, understand this is a very realistic result. Uncertain means that we've read through a gene and we have found basically a change that's different than the regular version that we expect to see, but we don't have enough data right now to really say whether this is actually truly harmful or simply just normal variation. In our world, we typically kind of go by innocent until proven guilty. So we treat these types of results as negative until proven otherwise. So we usually do not make medical management recommendations to change things off of an uncertain result. We really prefer to wait until there's more data available. And how that typically happens is very passive on the patient's end. So most patients will not need to redo testing on a yearly basis, genetic testing on a yearly basis. That's not really particularly helpful, honestly, in this particular situation. Instead, as the laboratories that we work with, as they test other patients, probably unrelated to all of you individually, as they find more individuals with the same change, they're able to kind of collate that data and come to a conclusion about whether they think this is actually harmful or not. The vast majority of uncertain results, typically about 90% of them or so, will eventually get downgraded to negative or benign, and only about 5 to 10% get upgraded to positive or harmful. So chances are most uncertain results, again, will become negative, and we don't like to be too aggressive with recommendations until we know a little bit more there. And then also, typically, frankly, especially with these multi-gene panels, you will have a result within each gene specifically. So if someone comes back with an uncertain result, it does not mean every single gene is uncertain. Usually it's gene XYZ is uncertain, gene ABC is negative, so on and so forth. Then we can kind of break it down further from there. And then what else should you expect from genetic testing? So our role is really to help provide what we call anticipatory guidance, kind of help with the psychological aspects of understanding having a genetic predisposition, what it means for both the patient and their family members, help with different perspectives on whether genetic testing may be a good idea for the patient or not. Some questions would be, especially from some of my patients that may not have children or maybe older, they might say, I'm X years old, how is this going to impact me? When am I really going to be doing anything differently at 75 or 80 or 85 and I have no children? That's a fair counterpoint. Maybe genetic testing is not the best option for that patient. Other people will say, I'm a certain age, I'm not going to do anything differently, but I really want to know this for my kids' information and their benefit so they can take steps as needed, but I'm personally not going to do anything differently. Or other patients will say, I want to know as much information as possible. I want to know every option that's available to me, and I want to be as informed as possible. Again, every patient is different. We recognize that. So again, as Danielle mentioned earlier, when you meet with us, it's not us forcing you to do genetic testing. It's really a mutual decision to make. Our goal is really to give you as much information as possible about this and really let you make the decision that is best for you. And then changes to medical management. So I touched upon this a bit earlier, but essentially some of the main things are that it could change. So when someone's positive, it could help us figure out what the best screening options are for them in relation to whatever cancer we think there's an elevated risk for. Again, earlier, more frequent screening, and then consideration of preventative options, whether it's hysterectomy, removal of the ovaries, etc., There are even certain options, what we call chemo prevention, a little bit controversial, but sometimes patients that have elevated risk can actually take certain things like tamoxifen to reduce risks of certain cancers like breast cancer. And then the other big portion of this, as I mentioned again, is treatment. That's really, it started a lot within ovarian cancer. It is spilling over into breast cancer, prostate cancer, and colon cancer now as well. So that's also something that, again, is very exciting on our side. That's really getting better outcomes for these patients that have these genetic mutations and certain types of cancers. And then one of the other really big things is impact on other family members. It's what we call cascade testing. To be open with you guys, it's really an abysmally low rate of cascade testing compared to what we think is really possible and really helpful. Honestly, one of the biggest benefits to learning about a genetic predisposition is for the benefit of family members, people who have not had cancer yet, so we can really take action to either find their cancers earlier or even prevent them. So really, anytime someone is found to have a genetic mutation, all of their first-degree relatives, so this includes parents, children, and siblings, all of them independently or individually have a 50-50 chance of having the same mutation as that original patient, or what we call a proviant. So like if a patient has a mutation, they have 4 kids, if the first child tests whether they're positive or negative, all of the 3 other children still have a 50-50 chance. Think about it like having a boy versus a girl. I'm sure you know some families that have only boys or only girls, or a mix, obviously, but whatever happens in the first pregnancy really has no bearing on the second for all independent chances. It's 50-50 each time. And then again, that really goes into the relatives' decisions about whether they want to really know about these risks or not. Again, a very personalized decision there. But the rates that we see cascade testing actually come to fruition is much lower than what we think it can and should be. So that's something very important in terms of family members. And then psychological impacts of testing. This is, I think, a very important consideration that is not really talked about enough. So really knowing this information, again, is not necessarily as straightforward as, okay, this is really good from your medical perspective. You know, your doctors can figure out how to tailor treatment, so on and so forth. We do recognize that some patients may not want to know this information for, again, multiple reasons. So some of it could be, you know, patients that are both positive and negative. There's various studies that have shown that a lot of them can report it impacts their mental and emotional well-being. Other patients will feel that they're empowered by this information, that they can do something differently. They can, again, get different care, so to speak. And then others may, you know, feel guilty about potentially passing it on to children, things like that. These are all, again, considerations to take into account before doing genetic testing. And this is really where another thing that really is a pet peeve of ours are a lot of even physicians, again, saying, isn't this really just a simple blood test? Like, yes, physically, in terms of doing it, it's not particularly invasive. It's just, yes, it is physically, a blood test is not you know, a biopsy or anything like that. But there's really, I think, that more goes into it than what really meets the eye initially. So it's more than just, you know, a routine CBC or other routine blood work. So again, even though it's physically easy to do, it's really important, I think, to take these considerations into mind, really figuring out whether it's really best for you and your family to know this information. And another thing that's very important to cover as well is insurance discrimination. So this is probably one of the biggest questions aside from cost that we get from patients. There is a federal law, it's called GINA, we abbreviate it GINA. What it stands for is the Genetic Information Non-Discrimination Act. This was passed in 2008. It is a federal law. It is separate from the Affordable Care Act. It's actually an adjunct to HIPAA laws originally passed in 1996. This is very specifically for health insurance and employment. So basically, this is meant to protect individuals. So say they test positive, to make sure that whatever it is, Blue Cross, United Healthcare, Medicare, et cetera, cannot come back to say, oh, we found out that you're positive, we're going to kick you off the coverage or raise your rates because you have higher risk. That is illegal for them to do. And then also with employment, it's illegal for an employer to say, oh, we found out that you have, you know, an elevated risk of XYZ cancers, we can't employ you anymore or whatnot. There are some limitations to this. One of them would be that it's only for companies that have more than 15 employees, and then it does not apply to the military. And then from an insurance perspective, it's really only health insurance. It does not include life insurance, long-term care insurance, or disability insurance. And this is something that we really encourage our patients, especially those that have not had cancer, if they are concerned about those insurance coverages, to get them set up first before doing genetic testing. Some of those companies, in particular life insurance, are legally allowed to ask on the application process about whether a patient's had genetic testing or not, and in theory can use that information how they deem appropriate in terms of what the premiums may be or offering coverage and whatnot. So another important consideration. And then for patients that have had cancer, for better or worse, usually that cancer becomes the pre-existing condition, and I don't think the genetic test results on top of that would really change much. So really, it's not as, from my perspective, is not as much of a concern for a patient that's already had cancer. It's mainly for the patients who have not had cancer to take this under consideration. So, and then let's see. So some of the main takeaways. Really, genetic counseling is a conversation between us and you, discussing your personal and family history, helping to figure out whether genetic testing is even reasonable to consider and what the results can be. Really, above all else, it is optional. It's really a patient's choice about whether they want to do testing or not. We have plenty of patients that they meet with us and they decide it's not the right thing for them. That's totally fine. It's not something that they're penalized for or anything like that. Some of the main things that we're looking for when we're talking about family history, again, the age of diagnosis, the rarity of cancer, and then multiple cancers within one person or on the same side of the family. And then genetic testing can really help your physicians with making the best screening recommendations or even treatment decisions. And then genetic testing results can really be very helpful for family members in particular. And then there are, again, some of those other concerns that are important to take into consideration, whether it's psychological concerns or insurance discrimination, things like that. And then cost, the one I didn't really go over, that's very difficult to generalize, but I will say most patients with cancer, if they meet some of those criteria that we're discussing earlier, most insurance coverage companies these days are very good about covering most, if not all, of genetic testing. And then at worst, if it needs to be paid for out of pocket, it's about $250 out of pocket now. Used to be about $4,000. And that's where kind of a lot of the media used to say, genetic testing is really expensive to do, which is true, but it's been probably about 10 years now where we've had a much more affordable price point. Again, $250 is still, obviously I understand a sizable chunk out of pocket, but it's much more attainable than what it used to be. So really the genetic counselors can also help you through on an individual basis, try to help determine and work with the laboratories to see what the best options are. All right, so we will, I think, stop sharing and then we'll take questions from anyone. They can include personal questions if you want as well. So I don't actually know how to stop the recording. I think.
Yeah.